going out to the world. So Phoebe and Elizabeth, I will let you guys take it over.
Great. I'll go ahead and share my screen.
Thanks, Dr. Martin.
Thank you. Can everyone see this?
Yes.
Okay, great.
All right, so good evening, everyone, again. So I'm Phoebe Dacha. I'm a resident taking time off to do clinical research, and Dr. Martin was kind enough to take me on and teach me how to be a good clinician and a scientist. So thank you, Dr. Martin. And I've been working with Elizabeth on a harm reduction approach to medication storage for pregnant and parenting women with substance use disorder. And I'll let Elizabeth introduce herself.
Hi, everyone. My name is Elizabeth Christ. I am a current undergraduate research fellow. I joined the lab officially this June to do some research in Dr. Martin's lab, and I'm a senior at Washington Lee University in Lexington, Virginia.
All right, so overview, we're going to be talking about the background, purpose of the study, methods, results, and under results, we'll have primary and secondary outcomes, as well as other interesting data, and we'll give you the conclusion of our research so far.
Right, so we'll go ahead and get started with the background. Probably a lot of this will be repetition of knowledge that most people know, but we'll just go through it to outline the reason that we wanted to look into the study a little bit more. The study was actually started by Erica. If anyone remembers her, she was a fourth-year med student last year, and she passed the torch to me and then Phoebe once she graduated. So her idea was for the study a while ago, and Phoebe and I have taken it on. But to go in some background of our study and a harm reduction approach to medication, opioid-related deaths are a lead cause of mortality during pregnancy, especially through 12 months postpartum. So not just while patients are pregnant, but 12 months after delivering, opioid-related deaths are a lead cause of mortality. And so, again, like we just talked about in our literature review, one way to mitigate opioid addiction and especially opioid-related deaths is prescribing buprenorphine and co-prescribing naloxone. And buprenorphine usually is taken in the form of sublingual films. And obviously sublingual films are pretty small, so they have the potential to be lost, but also stolen. So by a friend or a partner, the medication can be taken by someone else. And an issue when your medication is stolen is that you have to, correct me if I'm wrong, Dr. Martin, but I'm pretty sure you have to get a police report and then submit that to your pharmacist and pay for your own medication to be replaced. Is that correct, Dr. Martin?
It depends on the state, but in general, if you run out of a prescription for a controlled medication like Suboxone, gabapentin, etc., you generally will not be able to pick it up at the pharmacy until your original prescription was due.
Okay. So kind of along those same lines, buprenorphine can also be ingested by someone else, whether that's because it was stolen and someone else ingested it, or a child got into the medication and put it in their mouth. And this has obviously a lot of problems, but the two biggest ones are, A, if your medication is lost, stolen, or ingested by someone else, you can't take your own medication. And so you can't, that has the potential to cause a patient to go into withdrawal if they're not taking medication as prescribed. And then also it's hazardous to take medication that is not prescribed to you. So, and what's called a harm reduction approach to treatment, it's a way that approaches treatment, acknowledging that abstinence is attainable for patients and that taking, different approaches, including buprenorphine, but also what we're assessing is safe storage of your medication. Abstinence is attainable for all patients. And so there's currently a gap in literature, which Phoebe will talk about more in our primary and secondary aims, but specifically for our patients, which are patients with substance use disorder in an outpatient SUD clinic, how are these patients currently storing their medication? And then also, how does providing a lockbox for medication in this harm reduction approach help patients adhere to medication as it's prescribed to them?
Okay, so once again, to kind of piggyback on what Elizabeth has talked about. So the purpose of this study, we had two main aims. The first purpose and the first aim was assess the prevalence of current safe medication storage practices amongst a sample of pregnant and parenting patients, women receiving buprenorphine naloxone in an outpatient substance use disorder treatment clinic. The second purpose of the study was to assess the feasibility and acceptability of providing a lockbox for safe medication storage practices within the same population. So we'll see down the road how we were able to do that using the surveys.
All right, so a little bit more about our methodology. So the inclusion criteria for patients to be eligible for our study is that patients had to identify as a woman. They had to currently be a Motivate or an OB Motivate patient and currently taking either buprenorphine or buprenorphine naloxone. And the common names for those are Subutex or Suboxone. Patients were not eligible if they were on Sublocade, which is the shot. And the reason for that is you don't store your shot, right? You come into clinic to get that medication. And so it's not effective to give somebody a lockbox if they're getting a shot in clinic. Patients also had to have at least one child under 18 years old living in the home, and they had to be managing their own medication. So if they were living in a group home, they wouldn't be managing their own medications, so they did not fit inclusion criteria. So I'll go actually to the bottom of this list. Our source of recruitment, we recruited from two different sources. The first source was from patients presenting to Dr. Martin's clinic for routine care. And then the second source was from Dr. Martin's registry, which she's been working on for a while, but any patient who agreed to be contacted for further research studies and met inclusion criteria were contacted by phone, and we could send them surveys by text or administer it to them the next time they presented in clinic. And so the survey consisted of 3 steps. The first step was a baseline intake. And so after completing an informed consent form, so understanding their eligibility criteria, what the survey and study consisted of, patients would agree to participate in the study. And then we would, if the patient was in person at the clinic, give them a pre-survey on an iPad. And the pre-survey assessed questions such as demographics and experiences of homelessness and inter-partner violence, but also especially questions about how patients were currently storing their medication. So over here on the right, you can see an example of the section of how we asked questions about medication adherence and storage methods. So you can read them, but I'll read them too as well. Do you have access to a place to safely store your medication? How often do you store your medication in a locked or latched place? When you don't store your medication in a locked or latched place, where do you typically store it? So these are just a few examples of questions we asked, but you kind of get the idea that we're trying to ask different questions that paint a bigger picture of how patients are currently storing their medication. So after patients completed the survey, which took about 5 to 10 minutes, patients were handed a lockbox, and lockboxes came in 2 forms. One was with a key, a lock and key, and another one was with a code that they could set themselves. And then 3 to 8 weeks later, we contacted patients with a follow-up survey. So either when they were in clinic or over the phone. And the follow-up survey asked pretty much the same questions, and then it added a new layer of questions about the lockbox that they received and asked, did you use the lockbox? Did you like the lockbox? How often do you store your medication in the lockbox? Again, to try and assess our secondary aim of the feasibility and acceptability of providing the lockbox to our patients. And participants were compensated for these surveys. So $10 for the first survey and $15 for the post survey 3 to 8 weeks later. And the lockbox, I guess you could include as part of compensation.
Okay, great. So these are the results that we were able to come up with so far. So data collection is currently ongoing. So far, we have recruited 54 participants who have completed the primary survey or the baseline survey. And out of those 54, 32 have been able to complete the post survey. So in terms of demographics, we have 56.5% Caucasian, 40% are African American, and the remaining 3.5% are other. So Cerner doesn't quite distinguish who's who, so it's just 3.5%. We don't know how to categorize them at this point. The other thing is the mean age is about 30 with a plus or minus 4.6 years. And in the past 3 months, 12.5% have experienced homelessness and 4.17% have experienced intimate partner violence. And how we were able to come up with the IPV, so intimate partner violence score, there's a screening tool called HITS. HITS is hurt, insult, threaten, scream. So it was actually developed in a hospital in Chicago, and it's used to screen for intimate partner violence. So it ranges from the highest score is 20, and it's from 4 to 20. So out of the 2 patients, we were able to determine the HIT score of 17 and 20. And any score that's greater than 10 is positive. So that's how we were able to determine that. In terms of the primary outcomes, so we spoke about that briefly in the beginning. So the primary outcomes, we were able to obtain that from the primary, from the pre-survey, and the secondary outcomes were obtained from the secondary survey, the post-survey. So we'll talk about that in the next slide.
All right, so moving on to the primary outcome, the question, of course, we asked a lot of questions about how patients store their medication, but the question we were really interested in for the primary outcome was how often, if at all, do you store your medication in a locked or latched place? And we defined safe medication storage as answering always or almost always to this question. And so currently from our pre-surveys, we see that 26.9 of patients currently practice safe medication storage. So 26.9 patients answered always or almost always to this question.
For the secondary outcome, it was addressing the 2 main aims. So the first aim was the acceptability. So did they use the lockbox provided by the study? And we found that yes, in fact, 96.4% did use a lockbox that was provided by the study. The second aim was answered as well, and that's the feasibility, whether they were satisfied with the lockbox. And we didn't find that 96.4% of the people who received lockboxes were pretty satisfied with the lockboxes.
So moving on to just other interesting preliminary data. So you saw actually in our example of some survey questions, we asked if patients had access to a safe place to store their medication. And before the reception of a lockbox, only 53.8% of patients did have access, 53.8% of patients did not have access to a safe place to store their medication. We also asked patients, what are some of the biggest reasons that you don't currently store your medications safely? So why are you not storing your medications currently in a locked or latched place all the time? And 69.2% of patients stated that not having a place that latches or locks at home was one of the biggest reasons that they don't currently practice safe medication storage. Finally, from looking at the follow-up survey, we see that 96.3% of patients practice safe medication storage after they received the lockbox from the study. And just to bring you back to the pre-survey, only 26.9% of patients were practicing safe medication storage. So we see a big increase in the percentage of patients who are practicing safe medication storage after the reception of a lockbox.
So in conclusion, we were able to come up with 3 conclusions. So our findings suggest that currently patients do not practice safe medication storage. Patients who are on buprenorphine and naloxone, and we saw that percentage to be at about 26%. But after the intervention, the provision of the lockbox for medication storage, we found that it's feasible and is acceptable intervention for pregnant and parenting women. Our preliminary results also suggest that a lockbox is potentially effective in a harm reduction approach to improving safe medication storage practices amongst patients. And that's it.
Thank you. We'd also like to say a thank you to Dr. Martin and Bouchon and Madison and Erica who started this project. All of this would not be possible without you all. So thank you.
Yes, thank you, Margie, too. I see you there. Thank you for always looking out for us in clinic.
So we'd like to open up this time for just any feedback or questions you all have about what we've presented today. Like Dr. Martin said, we're submitting this for an abstract on Thursday. And so any feedback you have is appreciated and timely. So we'll go ahead and open up the floor for that.
That was a great presentation. Obviously, I'm very biased. I love the results. I had a question. What was and you might not know the answer, but you can tell me later. What was the mean follow-up time between the pre and the post surveys? Because I know we had a very large window when people could do the post survey. We made it like 3 to 8 weeks because we wanted to make sure we caught people whenever they come to clinic. Sometimes people miss appointments. So do you know how much time typically lapsed between the two surveys?
I would say it seems to be around 4 weeks. I don't know, Elizabeth, I don't know what your experience is, but it seems about 4 weeks. And you'll have the outliers. Some people don't respond up to the 8th week, but it seems around 4 to 5 around there.
We tried to contact patients exactly 3 weeks after just to get a head start. I haven't looked into how quickly patients responded, but we tried to contact them starting exactly at that 3 weeks.
Yeah, which was smart to try to catch people before they reach the 8-week window. You just when we get to the manuscript, you're going to have to report that. So putting it out there. Any other feedback or questions people had or points of clarification?
I have a question for you all that might spur some conversation. Is there any data you feel like we didn't present to you all? And for this, it's just the abstract, so we can't present every single finding that we had. But is there something as we were presenting that you all thought, oh, it'd be interesting to know more about how patients answered this question, or I don't know, just this is something that Phoebe and Dr. Martin and Bouchon and I have been looking at these questions for a long time. So it's probably easier for us to miss, it'd be interesting to see X, Y, or Z. So anything that caught somebody's attention or lack thereof caught someone's attention.
Can you go back to the slides that have your questions just to remind us?
Yes. There were a lot more, but here's some examples.
There are a lot more questions, just so you guys know.
Elizabeth, can we go forward to the results really quickly?
Yes.
That's a little question.
Primary outcome or secondary outcome?
Secondary outcome. So in terms of satisfaction, was that just this one question about so the first one talks about if they use the box itself and then if they're satisfied, does that mean that it worked for them? Like it was, say, practice, or they just used it and liked the box? Like what does satisfaction entail, if you could elaborate on that a little bit?
Yeah, I guess it's a good point. We probably should, define satisfaction. That I guess currently is up to the participant's own definition of satisfaction. But for our definition of satisfaction, it was answering very satisfied or somewhat satisfied to this question. So we're not saying anyone's saying that they were somewhat dissatisfied or dissatisfied, but we do see, I think that's one participant who just didn't use the lockbox by the study.
I think also like when you're the satisfaction means that it infers that it's feasible for them. It's easy for them to use. I think that's what we're inferring. We're not directly saying it's feasible, but because you're satisfied, we're taking that as being feasible, easy to use, and it's
See the correlation. Thank you.
Sorry if this is an insignificant question, but I was just wondering, because you said that you use two different types of lock boxes, one lock and key box and one coded lockbox. Was there any difference in like feasibility or in satisfaction between those two types? Just because I think you mentioned there was like 12 or 13% of people who also experienced homelessness. And so maybe I was wondering for them, would it might be easier to lose a key or something because of those conditions?
Yeah, that's a great question. We talked about that a few times as we were ordering lock boxes. We ordered a bunch of different kinds of lock boxes, different colors and, locks and codes. Phoebe, maybe you can take this one since you saw more of people receiving the code lock boxes.
Well, quite frankly, we haven't been keeping track of how many people who were actually getting the combination locks as opposed to the key boxes. The way we did it, I guess the last time we ordered boxes, we just did a 50-50. So 50 of 5 of each, 5 of each. So there seemed to be, I guess, acceptance for both. The patients are not particularly favorable toward one than the other. So.
Got it. Thank you.
Yeah, we were actually surprised by that because we thought people were going to have a strong preference for one or the other. But, we don't have the numbers to assess it in the research world because we didn't have all the options available. But anecdotally, it does seem like Phoebe said that people are just happy to have a lockbox. And so because so many of them don't. So we were actually surprised. We thought there was going to be more pickiness about which one people wanted, but no, people were just happy to have one, which was different than what we expected.
It's been really exciting to see patients as we give them the lockbox. I thought a lot of times they'd be like, yeah, I don't care about the lockbox, give me the money for taking the survey. And most of the time patients are most excited about the lockbox, saying, I wish I had this when X, Y, and Z. We see that a lot, which is encouraging and reflected in our data.
Well, I wonder
yes, sorry, Margie.
Oh, no, that's okay. Oh, hi, Dr. Tyson. Go ahead.
Hi. No, the clinicians, pop in because I was just thinking you and I are not researchers, but I was going to say just from the practical side, it has been amazing just to see the enthusiasm and relief from our ladies when they get this. And I was just thinking to myself about the punch code versus the key thing. So far, knock on something, I haven't seen a request for prescription refill because someone has lost a key, but we'll certainly keep an eye out for that moving forward because that is an easy thing to do. But strong work, everybody. It's really great to see your very practical and impactful research in action just as a peon clinician. I love it.
Yeah, I was actually just thinking that how wonderful it also is to be having that protection for children as well in the home. Because I have had more than one patient tell me that, their child got their strips and just kind of like throw them all over the room or whatever. So I think that's nice that they have that. I'm also wondering if with the key, if they did lose it, could they get another one? I mean,
So the lockboxes came with 2 keys. Whether or not they separated the 2 keys is a different question, but I don't know how you get another key to your lockbox, just smash it open or
Well, that's
I'm
what
not sure what you do in that situation.
they have to, so that's nice. It's also really nice too, because sometimes I know patients just need a place for their medications that someone else is going to be monitoring.
Mhm.
That they're handing that lockbox probably over to a family member who's then handing their medicine out to them and can put whatever code or whatever to hold the key, you know. So I think it serves so many different positive, you know, benefits from this.
Right. And to your point, Margie, about children getting into medication, in my literature review, I found this whole website on the CDC's page called the Up and Away campaign. And they had a bunch of, funny pictures and stuff, but it's this campaign for not just buprenorphine, but all medication that parents should be storing it up and away out of children's reach. And, the bottles that are hard for kids to get into, for all kinds of medications, and having these conversations, even with strangers who come into your house, if our medication is stored away. So yeah, it's obviously applicable to all sorts of medication, but especially to buprenorphine.
For your, oh,
Sorry, go ahead.
that's okay. For your question about what else might be interesting, do you have any information? I know that's not the focus of the study, but about how this did impact the bupe use, or like having medication stolen, like other like events happening before that didn't happen during the time they had the lockbox, or that they felt like they took their medicine more in line with how it's prescribed, or any information about that kind of stuff?
Yeah, Phoebe, do you want to take that one, or I can answer it too? I think you're muted.
Sorry. No, we don't have that data, but I was thinking as Dr. Tyson was talking and Margie was talking as well. I mean, those could be great future studies, directions for future studies to see, what happens. Are patients losing their prescriptions as much after the lockbox intervention, or are kids being exposed to hazardous medication, or even, what you're referring to? I guess we can always look at it from another angle. So I think those are really good future direction questions. And yeah.
I would add to that too, and we haven't done this yet, but we ask pretty much the same questions in the pre and post survey, except for in the post survey, we ask did you like the lockbox we gave you? And some of those questions are, in the past 3 months, how many times have you lost your medication? Or how many times has an adult gotten access to your medications? How many times has a child gotten access to your medication? And a lot of branching of, if they had access, did they ingest it? And so we haven't done this yet, but we could do a side-by-side comparison of how those numbers changed. If they answered 3 times in the past 3 months, is it still 3 in their post survey? So great question, Annabeth. We haven't looked at that yet, but.
Sorry, Elizabeth, I was just trying to help you with that. So I don't know if this is the pre or the post, but we do have questions about if you've missed any doses over the last 3 months, and then if you've been able to take it. So that is something that we can look at it later. So here it does say that the 2 graphs here, so it doesn't say miss or something like that, but we can look at that with the data we have. So, and just the one more thing I'd point out with the question that earlier came up about people who were homeless. With our data, out of 52, we only had 7 people who had said that they experienced being homeless during the study period. So maybe we weren't powered enough to be able to get that number or see that difference, because 45 out of 52 didn't have that issue. So maybe if we get more numbers on that, maybe we can ask that in a follow-up or something like that, but that's a good question too. Yeah.
Thank you, Bhushan. That was helpful to see.
The other thing clinically that patients have mentioned to me in visits when they get their lockbox is they'll just go into how anxious they always are about their kids potentially getting into their meds. And I I think we asked that, is like how worried you have been that your kids maybe get into your meds. And so I think last time we looked at the numbers, it wasn't the prevalence of people saying that kids had gotten into their meds was low, thank God. But the anxiety about their kids potentially getting into meds, that is just kind of putting my clinical hat on. And that has been something that patients have mentioned to me a lot. It's like, oh, I'm so happy to have this lockbox. I've been so scared that so-and-so, my kid, is going to get into my meds. So maybe from a research perspective, I don't know if we asked that pre and post, but clinically, that is something I've been seeing a lot. Well, we're nearing the last minute. Does anyone else have any other feedback or anything else for this study as we are writing it up? This was really great discussion. We appreciate everyone's feedback. Well, if not, thank you, Phoebe and Elizabeth. That was a great presentation. I think we got some great discussion and ideas from the clinical and the research side, which makes my heart very, very warm. So that way we will end then. Thank you guys all for coming out to our lab meeting tonight. We appreciate everyone coming, and we will see you all next month.
Thank you for your work.
Thank y'all.
Thank you, guys.
Bye.
Thank you.
Thank you.